Hello, this is Dr. Gay from First Lake MRI, and this is a patient born in 1953. They're a swimmer and they had shoulder pain, and they had a couple findings here. Number one, their AC joint, there's some really mild arthritis of the AC joint, and their glenohumeral joint looked really good. And beneath the AC joint and beneath the acromion here, we have a little bit of darkness. This is a little bit of bursal fluid in the subacromial subdeltoid bursa. This motion limited view here, we can see fluid above the rotator cuff. Here's the humeral head. Here's the acromion, and there's that fluid, so a small subacromial subdeltoid bursal effusion, meaning acute bursitis. I think we can see it on this maybe best. Here we go. Yeah, so here it is. The rotator cuff looked great. There was no evidence of tendinopathy or tear, just this bursitis. The other thing was a tear of their labrum. So this is the superior labrum along the posterior aspect. This is probably the posterior third here. And here's the middle third at the 12 o'clock position. You can see that vertical tear, the superior labrum again back there. And now here's that vertical tear. Now the anterior thirds is right here. And you can see that the biceps labral anchor, you can see the biceps coming out here. This is the biceps labral anchor and anterior third. And you can see the tear goes there. So it's a tear involving the superior labrum, the anterior two-thirds. And also notice that down here things look too thick and too gray. If we put up the T1 images, you see the same thing where the inferior joint capsule, anterior joint capsule are just really thick and gray. And so when you see this, think of adhesive capsulitis. And very often, if they have clinical history of adhesive capsulitis or the doctor is worried about that, they'll have the thick joint capsule, and they'll not always, but very commonly have a tear of their labrum. A lot of times it's a very small tear, and the doctor's not even suspecting that, but I've noticed a high association between labral tears with the adhesive capsulitis. So in this case, they have the labral tear, they have this thick joint capsule, and there's another place I like to look to if you're nervous, like, wow, this is a little thick, but not that thick, I don't want to mention it. Think about a couple things. Number one, do they have much joint fluid? So if they do not have much joint fluid, that goes along with adhesive capsulitis. And here you say, gosh, I don't see any joint fluid. If a labral tear, you think maybe it would kick up a joint effusion, but without that joint effusion, that gets your suspicion up. When you see this very thick and gray on this view and on the axials as well, definitely think about that. And then the third thing is the coracoid process here, right along the medial margin, kind of inferiorly. There's usually a little triangle of fat right here. Brightest here, just as bright as this cutaneous fat, a nice little fatty triangle. And when you see it just gray like this, completely grayed out, this is inflammation that's gone into that area. So this is really an indicator as well. So this patient almost for sure has adhesive capsulitis, though they didn't have the history of that, associated with a labral tear and then the bursitis here. And again, think about the joint capsule being thick. They have maybe a labral tear possibly associated with it, and then look for that little triangle here of fat, which is a great little trick to really sway you one way or the other, whether or not you're going to come down hard on it or mention it at all. So thank you very much.